I just feel so honored to be here. Thank you very, very much. I feel like someone in the audience said that I relived my childhood as somebody in Paraguay with her own hefty luggage of learning challenges. I wish that I had been surrounded by the speakers today. I think it would have been an easier life. But one of the themes that I want to talk about today is how trauma happens to all of us and we grow from it. And I bring actually a point of view that I hope is complementary to the focus on learning that we've been hearing in this very illuminating day. You know, I think one of the things that we have found, is this?
Yeah, there's a, I think you have to push OK.
Say that again.
Sorry, right here. Oh, you're fine.
I am fine.
Oh, yeah,
Good.
you're fine.
Okay, great.
And we can hear you. Do you have
You
slides,
can hear
though?
me? Yes, I do. It's just that I'm going to talk a little before my slides.
Yep.
Is that okay?
Yep.
Yeah.
Let me just, trying to get the, okay. There. I think I figured it out, which I am not technologically
You are
savvy.
great. Thank you.
It's not my gift.
My lens is the lens of early childhood, and I think that all of us, there is an expression in Spanish that we all remain 20-year-olds and 2-year-olds in some part of our hearts, and I think the reason I wrote The Emotional Life of the Toddler was because the toddler part of me needed help when my son became 15 and would say no and would not take my no for an answer. So we find that young children with biologically based learning difficulties can be very frustrating to their parents and their siblings, long before their learning challenges might be identified. And we've worked with some parents who used adjectives, and I'm going to share with you some of the milder ones, adjectives for their children like stubborn, disobedient, manipulative, uncaring, defiant, dumb. And mental health people like me have a lot to learn from you, people in the learning field, about how to best assess, treat, and refer children that have learning challenges. And what I hope I can contribute is a lens on how parenting can exacerbate the learning disabilities through critical and punitive responses, and how guiding the parents to understand the origin and meaning of children's challenging behaviors can free them to internalize the content once their feelings are under more modulated control. I carry with me a particular 5-year-old who became suicidal after being repeatedly hit with a belt and told by his parents that he was a bad child because he could not follow the parents' instructions. And I think children and families like this, at the most extreme end of the spectrum, where learning difficulties and mental health difficulties overlap, both for the parent and for the child, need all of us to come together to take care of them and for us to engage in a dialogue to each other. And that's one of the reasons I think that the title of this conference is absolutely perfect, because it speaks to what we urgently need to improve children's physical and emotional health and their capacity to learn, all of which go hand in hand and influence each other. In attending to the whole child, I want to suggest that we're facing the challenge of a striking disconnect between what we know and what we fund. And I think that this conference really puts forward what we need to fund. Tom Insel, who was the director of NIMH between 2002 and 2015, has a new book called Healing, or Path from Mental Illness to Mental Health, where he says that over the past decades, scientific progress in neuroscience has been stunning, but public health outcomes have become steadily worse, with very dramatic increases, which were discussed by Kenisha Sinclair McBride in her wonderful talk, in key markers like child anxiety and depression and suicidal ideation, and suicide rates and overdose deaths, which I think can be described as deaths of despair, which culminate years of erosion, pain and unaddressed suffering. I believe that these trends, this worsening, and another statistic that I want to highlight is that maternal mortality is steadily increasing in the United States, whereas it's decreasing everywhere else, including in the third world. And it is now 40 Black women dying in childbirth per 100,000 versus 12 white women per 100,000. So these disparities are really particularly affecting people of color and children of color. I believe that these trends of worsening public health outcomes are the results of years of erosion in the social contract, which is the implicit agreement among the members of a society to cooperate with each other on behalf of a shared understanding of the common good. And a conference like this is invaluable, I think, in helping to recreate a shared understanding and build a caring community of partners across disciplines collaborating to help the whole child and the whole family. As a background for my talk, I will focus on three major areas of this disconnect between what we know and what we do on behalf of children. The first involves the treatments we choose. We know that relationships are at the core of physical and psychological health across the lifetime, and that for children specifically, family relationships are the security of their early attachments shape brain development and social and cognitive functioning. We also know that loneliness consistently emerges as a public health problem, with 60% of Americans saying that they often or very often feel lonely. And yet, individual psychotherapy and medication management are the norms for treatment, more often with a focus on what is wrong with the person than on improving the context of their relationships. The barriers to an inclusive, family-focused approach are particularly harmful for children because their relationships with family members shape their sense of self from the earliest years of life, and for them, individual treatment puts them in the paradoxical situation that it's their clinician who knows them best, rather than the parents and the people who raise them, and that it's with their clinician that they can really share what their innermost pains and fears are, rather than with their parents, and that there is often no constructive dialogue between the parents and the child clinician. The second disconnect between what we know and what we do involves the lack of consistent attention to the role of adversity and trauma, and I want to thank Lilia Espinosa earlier today for speaking so eloquently about the trauma that is faced by so many of the children in our care. Stephen Sharfstein, who was the president of the American Psychiatric Association some years ago, made a memorable analogy in 2006 when he announced the formation of a task force to study the impact of violence on children. He said that interpersonal violence, especially violence experienced by children, is the largest single preventable cause of mental illness. That's powerful. What cigarette smoking, he added, what cigarette smoking is to the rest of medicine, early childhood violence is to psychiatry. We are surrounded by violence. And yet, in spite of this, screening for exposure to violence in the family and the community and for other traumatic events is the exception rather than the rule. And I spent the last 25 years trying to persuade people treating families to screen for violence and traumatic events. My program is called the Child Trauma Research Program. So we wear our name on our sleeve, right? The children who are referred to us are children who are traumatized. On average, the referring source knows about one traumatic event, one type of traumatic event that happened in the child's life. It might be physical abuse, might be exposure to domestic violence, it might be exposure to violence in the community, an intrusive medical procedure. When we screen, when we ask specifically, has this happened to your child? Has this happened to your child? Has this happened to your child? Turns out that on average, these children under 6, birth to 5, on average experience 5 types of traumatic events. And in the ACE study, we know that 4+ traumatic events are associated with the 9 leading causes or 10 leading causes of mortality and morbidity, and with 20 years less of life expectancy than people who have less than 4 ACEs. And these little ones have had, on average, 5 types, and their parents have had, on average, 13 types of traumatic events. So we need to assess what happens to people, because trauma is really much more pervasive than we allow ourselves to know. And the ACE study, which was done with 85% white people, 100% middle-class people, all employed, all having health insurance, 85% of them said that at least one type of traumatic event had happened to them, and almost 20% said that 4 or more types of traumatic events had happened to them. So there's still a prevailing misconception that screening for trauma would be traumatizing in itself. And what we actually find in doing it is that people express incredible gratitude and relief that they no longer need to feel that they are secretly carrying something that didn't happen to anybody else. Because what we say to them is, the reason we're asking these questions is because at least 1 or 2 of these things happen to almost anybody. But people don't like to talk about it, and so we are taking the step of saying, if we know about it, we will know how to help. We can think together about how did it affect you and what helps you and who helps you. And then we can create a path forward. And for many parents, learning that things that happen to their children are actually connected with the symptoms that are most difficult for them to deal with can be like a aha experience that normalizes the child's experience, and that connects to what might have happened to the parent in their own life, so that they now understand themselves and their child better than they did before. The third disconnect is the persistent neglect of the emotional health problems in the first 5 years of life. We know, and it's been said before, that during this period, the brain develops fastest and creates persistent patterns of understanding about relationships, about the world, and about the self. Specifically, about what is safe and what is dangerous, because the amygdala is almost fully formed at birth and fully developed by the end of the first year of life. What to pay attention to and what to expect about how we will be treated. When we do cognitive tests for the children that we see, we often find that, let's say, the bell rings and they instantly stop being able to pay attention. One child said, "What's that? What's that? What's that? What's that?" And then we found out that the ringing of the bell was the coming into the house of a perpetrator. Another child completely decompensated when he was asked what a knife was. And he went into an altered state where he said, "Cut, cut, kill, kill, cut, cut, cut." And he could not stop talking about it. And then we had to come into a state of what Bessel van der Kolk talks about, trauma lives in the body. And we're coming to his body and helping him look around and saying that he was safe here, that this knife was in the book and was not here, helping him breathe, helping him blow bubbles, brought him back to a place. But it helped us understand the difficulties that he was having in the classroom and the dysregulation that would come over him with triggers that nobody else knew about until we found out what he had witnessed. Despite knowing how important the first 5 years of life are in terms of brain development, social development, cognitive development, there is a dearth of infant and early childhood mental health programs in the country, and this topic does not receive anywhere the amount of attention that it needs in the training of social workers, psychologists, psychiatrists, pediatricians. And an overarching theme linking all these disconnects is that children of color are disproportionately affected by these discrepancies between what we know and what we do. And they are particularly at risk for not receiving culturally appropriate services because less than 10% of psychiatrists and psychologists are people of color. Today, I want to describe briefly how the UCSF Child Trauma Research Program has been trying to break the barriers between in these areas of disconnect that I just mentioned. And now I will, I was supposed to be telling, this is the title. Thank you. This slide is a brief synopsis of why the first 5 years of life are so important as the focus of prevention and intervention. More children are injured and die from maltreatment and accidents during this period than at any other time through young adulthood. Young children, particularly children of color, comprise the largest proportion of children in foster care. And they stay longer in foster care, and they are less likely to be returned to their parents. Numerous studies document the damage that can be caused by early trauma. When compared to controls, children exposed to trauma show anatomical differences in brain structure in the form, for example, of smaller brain volumes, smaller hippocampus, elevated cortisol levels, and accelerated telomere shortening. They show lower scores in cognitive tests, including IQ, memory, vocabulary, and language complexity. More negative affect, aggression, and ambivalence in relationships with adults and with peers, more internalizing and externalizing behavior, more psychiatric diagnoses, including PTSD, separation anxiety, and oppositional defiance disorder. These effects are long-lasting unless conditions change, with negative effects of early trauma being apparent as long as 9 years later in the longest longitudinal study that has been conducted. And these findings made then a compelling case that neuroscience can help us understand the enduring aspect of relationships. The research also shows that protective factors ameliorating the impact of early trauma are consistently related to relationships. Family and neighborhood cohesion predict lower levels of antisocial behavior in children exposed to violence, so that it serves as a protective factor even in risk situations. Positive patterns of parenting and secure attachment are consistently associated with child resilience in the form of less disruptive behavior, better relationships with teachers and peers, better IQ scores, and more capacity to learn. We used this information to develop child-parent psychotherapy, a relationship-based, family-focused, trauma-informed treatment for children in the birth to 5 age range that we're now expanding to older ages as well, in response to clinicians who are saying to us that they use this formulation triangle that I'm going to describe in a little bit with older children and even with adults, and that it works very well. We meet with the child and the parent together, and we help them show us and tell us what happened to them and how it affects them. These young children are often our best teachers. One 4-year-old, Lenny, was referred to us because of her aggression in preschool. And when we assess her cognitive functioning as a regular component of our assessment protocol, we found a very impoverished vocabulary and pattern recognition, along with difficulty focusing and low frustration tolerance. She was also a very scared little girl. And on the second session with her parents, she said to her father, "You need to say sorry to my mommy because you hit her." Not nice. There was a stunned silence that followed that statement. But the clinician thought to herself, in this session where the agreement was that people could talk about anything that they wanted to talk about that was worrying them or was making them happy, she found the courage to speak for the secret behind the aggression towards peers that had led to the referral, because we know that children learn by imitation. We find so much value in naming aloud the frightening specifics of our clients' lives that we coined the term speaking the unspeakable to describe the core of our treatment. And we created a simple clinical formulation, what we call the CPP triangle, to normalize traumatic stress responses and create new and supportive meanings, so that we can make explicit connections between what happened to the parent and the child and their symptoms. We might say, for example, you saw your mommy and your daddy fighting and hitting each other, and now it's hard for you to sleep, and when you get upset, you hit your teacher, and then you feel really bad, and that's why your mommy and daddy are here, and we're going to be working together because they don't want to hit, and they don't want you to hit, and we're going to think together of how everybody can get along better. In the case of Lenny, the clinician said, "Lenny, you are saying something very important." And then she turned to Lenny's mom and dad and asked, "Do you have a sense of what Lenny is talking about?" So that they had the permission, the respect to respond to Lenny themselves. And this led to what at first was a very awkward conversation. I don't know what she's talking about. Well, don't really. And then the mother said, well, when you slapped me. And he said, well, I didn't mean to. And then that became a conversation that encompassed everybody. And as these conversations became real, candid, thoughtful, talking both about the anger and the fear and the pain that are often under the anger, Lenny could play with the dinosaur, with the wild animals, with the mom and with the family of dolls, and the hopes about what the family wanted things to be like for them. And Lenny's aggression decreased, and her frustration tolerance became much, much better, and she stopped having problems at school. This is a manualized treatment. We have 4 books, one that focuses primarily on domestic violence, one that is for the pregnancy area, and one that focuses primarily on grief. And there are 5 randomized studies conducted by 2 separate teams, one at Ucsf and one at the University of Rochester. And the research has involved predominantly culturally diverse families, including family violence and maltreatment in the child protective system. And I'd like to just give a few highlights. Children who received CPP show significantly greater improvements in symptoms of PTSD. The graph on the left shows the number of children who met criteria for traumatic stress disorder before and after, and we see significantly decreases from pre to post for the green group that received CPP, but not for the orange group, which received individual treatment as usual. And on the right graph, the mothers who participated in CPP in the green light showed greater improvements in their symptoms than comparison group mothers who received individual therapy. And then because of the interest in ACEs and the fact that 4 ACEs or more lead to greater problems in health, we particularly focus on the children that had more than 4 ACEs, and we found that the results continued to be present, that the CPP group did best, and the ones that had CPP plus also improved significantly in decreasing symptoms. The same thing for security of attachment. This is in maltreated children who were very anxiously attached, and it's interesting that here you have the green group, which is the CPP group, and then the teal group, which received parental psychoeducation. And at first, the post in the parental psychoeducation did just as well as the ones in CPP, but on follow-up a year later, the CPP group continued to retain its improvement, whereas the ones who received parental psychoeducation, the improvement decreased. And we think that it is because in psychoeducation, we don't talk about feeling so much. We teach, but we don't connect content and feeling. And what Goldie Hawn and Laura said today about how feeling, thank you for asking that question, because it was really the core question, that unless we talk about feeling, content stays here, but does not really affect the body in the way that feeling affects it. This is a storytelling task where children who receive CPP had much more secure and coherent descriptions of their relationship with their mom and their dad than children who were in an individual treatment group. And this is the one about cognitive functioning, which is particularly children of depressed mothers, where the cognitive score, the score in a cognitive test, in an IQ test, went up for children that received CPP in comparison with treatment as usual in the community. And we had the same finding for children in a study for children exposed to domestic violence, who some of them improved as many as 20 to 30 points on post, particularly on the capacity to articulate, to respond, to put things into words, and to identify patterns. And we think that there is something about releasing fear, about actually talking about what happened, actually giving words to feelings, that frees cognition so that it can be deployed to non-emotionally charged learning tasks. We also find that morning cortisol gets more stabilized with a family-focused approach than with an individual treatment approach. And the most recent finding that we have from Nikki Bush at UCSF, a dear colleague, is that CPP is associated with a deceleration in cellular aging in the telomere. There's less rapid aging or shortening of the telomere, and there is even evidence that as a subgroup of children have a lengthening of telomere. So what we're finding here is that an approach to relationships, an approach where the parent and the child are helped to come together, understand each other better, and create greater protection and safety in the home, affects the whole child, from the biology to the capacity to learn. The CPP triangle is the core of our work, and we extend it to different populations: pregnancy and the perinatal period, high conflict child custody, and traumatic grief when a loved one dies. And the three ovals at the bottom show brief group interventions for parents under high stress and teen parents, immigrant and houseless families, and families torn by war. There is a study that was just published in the Global Health Lancet that we did in Colombia, where we find that semillas de apego, attachment seeds, resulted in major changes in the parents' capacity to see, understand, and support their child's fear and trauma from the 40-year civil war in Colombia. And that was a very, very powerful finding. One of our central themes is that we do not need to be therapists to be therapeutic, and we're extending the CPP model to primary care, child welfare, and the courts. One example is CalQuick, a UCSF partnership with the California Office of the Surgeon General to screen for ACEs with patients on Medi-Cal, where we adapted the CPP triangle to become triads, a screening framework that guides the healthcare team to explore the possible links between their patients' health problems and their life conditions, and to engage them in a realistic healthcare plan. And what finding is that when doctors and nurses can talk to their patients about their life difficulties, patients are more likely to follow the treatment plan, and the healthcare team feels more satisfied and less burnout with their work. Another example is our collaboration with the National Health Start, where we are helping Head Start teachers and administrators to recognize the behavioral manifestations in the preschool classroom of adversity and trauma in the forms of disruptive and aggressive behavior, persistent separation problems, and other manifestations of stress, and help the teachers respond in a way that supports and protects their child. Our central theme, again, is you don't need to be therapist to be therapeutic. Trauma is universal and it hurts, but people of all ages can grow from it. Leonard Cohen wrote, "There's a crack in everything. That's where the light comes in." Our job is to witness the crack, I believe, with deep empathy, and then cultivate children's and parents' ability to see their own ruptures and to seek ways of healing them. I was driving around Santa Cruz the other day and found this graffiti from what I like to think is an anonymous philosopher who wrote, "If nothing changes, nothing changes." And then my dear friend Ken Epstein, who you will have the pleasure to hear tomorrow morning, wrote, "What will change when a system becomes trauma-informed?" And he answered, "Everything." And I hope that this is a dialogue where we can start thinking together about how we can change everything. Thank you so much.
I'm sure that this audience of all audiences recognizes how valuable the research you've done is, how it's not a subject that's easy to jump in and like say that, it's not what you go home at night and share at a dinner party like what you do at work in the day.
Although taxi drivers love to talk about it.
Yes. Yeah, exactly. Although what you find sometimes, Uber drivers might have been psychiatrists in another country and now they're having drive taxi,
So right.
Ubers.
Yeah.
One of the things, if people haven't picked up on what I do a lot of translation work, right? And part of what gets me really excited is getting to connect with someone like you around your work and then say, I wish people understood how important this is. And I'm going to tell you, and I want to get your response to it, I'm going to tell you a couple words, because, I look at your titles. In case people don't know all of Alicia's titles, Director of UCSF Child Trauma Research Team, Chair in Infant Mental Health, Vice Chair Academic Affairs, UCSF Department of Psychiatry. Okay, so let's start with the first one and the word trauma. Mm-hmm. Now, what if I tell you that when I go out into like the general public and I'm going to talk to somebody about something related to any of what you just presented and I say the word trauma, what I imagine is the little thought bubble above their head is somebody getting hit with a baseball bat. Mm-hmm. Right? Yes. So that and again, we all kind of come to realize how important it is, but how do you help people understand that it's not that sort of narrow traditional view of trauma like something got broken, something got hit, something got cut. Again, I always say narrow medical kind of view of the word trauma, and expand it to something inflicted upon someone. Doesn't have to be physical, can be mental, psychological, emotional, but that it has as very much, if not more, impact, and we need to take it as seriously as we would if they come in bleeding, right? How do you deal with that? Because again, you tell people I'm head of the child trauma research team, and all I think people think then, it's physical or sexual abuse, and they're not thinking of the broad sense of trauma.
Mm-hmm, mm-hmm. It's interesting. I almost have the opposite problem.
Okay.
But I will answer your part of the question and then I'll give my part of the question too. Okay?
Excellent.
Everybody here? I just want to
Here, let's make sure.
know. In the back.
There you go. Here, just put it close. Now
Okay.
You should be good.
Okay. So first of all, I have a very those of you familiar with the DSM, right? The DSM 1, 2, 3, 4, 5. It's a very handy thing. It has lots wrong with it, but one handy thing is that it defines trauma. And it has a very circumscribed definition of trauma as something that threatens your life or the life of somebody or the integrity, physical integrity of somebody. It's an event that happens unexpectedly, unpredictably, is overwhelming your senses and it prevents you, immobilizes you, so that in the moment of trauma, you cannot respond. You are frozen. You can't process it. And in the moment right after it, you take flight, you fight back, or you freeze. So it's really very, very powerful. It's a death and life experience. And it can be a life or death experience physically or mentally. And I think that most people, because it's happened to most of us at some point or another, that, they have ha experience. The part where I go the other side is that, like everything else, there is a wonderful linguist called Vygotsky who said that words are like neighborhoods. They have a core, and then they go, expand, and I think the same thing happened with trauma. So that now the word trauma has been cheapened a little, and people feel like they are traumatized by not getting in the school that they wanted to get to, or by, you get the message, right? And so one of my jobs and my team's jobs is to push back and saying, that's actually very stressful. I can understand that it's very difficult, it's painful, it's frustrating, but it's actually something that you have the capacity to cope with. It didn't happen unexpectedly. It didn't threaten your life. It didn't, and then people get a little offended that we're not honoring their pain the way we're supposed to honor their pain. But what we want is to help people have a perspective on their own capacity to deal with what is difficult stress versus traumatic stress, so that when something traumatic happens, they really know the difference. Does that make sense?
I think it's hugely helpful, at least for me, to have that distinction, because I think sometimes then people minimize the sense of trauma because they have the part that's not incapacitating, but they think they know what something was. I was very traumatized. It was a very traumatic experience. To be able to help people understand that the work and what we're talking about with, whole child and incorporating that into our approaches, that we're talking about children, and not only, it's not just physical, and it's, it's the physical, mental, emotional, and you can tie those pieces together, right?
Yes.
And for an education crowd, it's sort of the no duh impacts your ability to learn, for example,
Yes.
right? Shuts that part down.
Yes.
So it was a very helpful answer. Now I'm going to give you another one. Especially just because I do a lot in the early childhood space, right? Early brain and child development. And on the one hand, I get very excited that, often it got left out of the discussion altogether. So great, we're talking about the earliest years. But I have to say, when I hear infant mental health, again, my concern from having to communicate this out to the masses is that, again, I see the little thought bubble over some people's heads, and I think they're thinking about schizophrenic babies, right? And the reality is that we've thought about mental health has really been mental illness, right?
Yes.
And mental illness is bipolar depression, schizophrenia, as opposed to more of the continuum and recognizing, you can look to extremes of things, but that how would you define for people what is infant mental health? Because I think doing that helps us explain that this isn't some like, oh yeah, I don't really believe you and you're making a big deal out of it, because what do we know about infant mental health? Infants can't even talk. How do you explain that?
Well, I'm very honored that you are asking me, because I helped 0 to 3, the center where you and I met, to craft the definition.
We met when she was being honored, I think, with what, like a Lifetime Achievement Award or something, when we met? I think yes. So anyways, just,
Thank you.
yes, we met.
I'll go back to Freud. Freud was asked, what is mental health at a conference like this? And he, off the cuff, said, is the capacity to work well and to love well. Freud said that. Isn't that like incredibly friendly? And what I like to say now is the capacity to love well enough and work well enough, because I think we all have our glitches in our capacity to love and our capacity to work, right? Particularly after 2 years of the pandemic, right? And so for infants, I paraphrased it. And I said, is the capacity to grow well and to learn well. And then we put it in 3 categories. The capacity to feel feelings and modulate them, the capacity and recover from this modulation, because I like to think of life as a chiaroscuro, a combination of light and shadow, where the light is marvelous and the dark is inevitable and actually heightens the appreciation of the light. And so I always like to put the other side so that it's modulating feeling and recovering from dysregulation. To establish secure enough relationships and to repair when there is a collapse in the trust. And then the ability to learn and enjoy exploration and learning, and then pick yourself up after frustration and continue learning. So it's kind of like the counterpoint, the balance between things going in a momentum towards growth, and then when things stop, to regain the momentum. Does that speak to you about what mental health-
Absolutely. It's very helpful. And I like to, again, one of the phrases that I've started to use is, if we look in the context of today and why you can get people to pay more attention. You say, what's going on in the world today? No one's going to argue a very rapidly changing world.
Yes.
Which means it's less predictable, which means you're going to come across things that you weren't anticipating, which means you need to overcome those, unexpected. You're going to fail because you don't know the answer yet. It's not just a matter of knowing the answer, but facing, things. What you're talking about is sort of that early development of that capacity to say you're going to face an obstacle, and it might be just a day-to-day obstacle,
Yes.
and then overcome it, which has become a really valued skill. This is where I quote like the World Economic Forum list of top skills needed to succeed in today's world and workforce. And that is one of the most coveted skills, is this adaptability, which of course you just very articulately related to infants and relationship and modulation, and not getting rid of all obstacles, but helping develop the skills to overcome them, I think is really valuable. It's how I get people interested in executive function skills and their most rapid rate of development between the ages of 3 and 5.
Yes.
Because we're talking about cognitive flexibility is one of them, and the ability to shift gears when you face challenges. So my next question for you then, and again, the fact that you're sitting here in this group, and presenting to this, it's an interagency symposium, is fantastic. My question for you is, I look at your work and I say, if only everyone knew about this, right? Whether it's the business people, looking at like, why do we invest early? Or if it's the healthcare system or the educators, how often do you find that you are brought into those other realms versus the people recognize what a treasure you are in your own space, right? Trauma-informed care, but doesn't yet cross over? Because I think the sense I get from this group is that is the goal. And the fact that you're even here kind of speaks to that. But how often do you find yourself, whether it's an education-driven conference or a pediatric-driven conference, or does it tend to be some enlightened few crossover?
Actually,
groups?
more and more, and we do, and it's not just me. I have a marvelous team of people, and for instance, we're at the border with Mexico. Right now, we're working with Ukrainian refugees in the border with Mexico, but we were working with, children and families from Central America coming through the border. We're in Colombia, working with economists. The people that, this was unbelievable, the people who did the randomized study that was published in the Lancet Global Health are 2 economists who somehow read about child-parent psychotherapy in Colombia at the Universidad de los Andes, and went to the United Nations and asked for funds to bring child parent psychotherapy to Colombia. It turns out that Colombia doesn't have psychologists and social workers and so on that in enough quantity to treat. And so we developed this group setting. So in the last 2 months, I gave 3 talks to judges.
Oh, wow.
So that the triads is for primary care providers. So there really is an increasing awareness, I think, of how trauma really permeates every aspect of life. I've been a consultant to Child Protective Services for the last 40 years about how to ameliorate the impact of trauma on families and how to minimize the need for removing children from their homes. So more and more.
And I would
I'm very
imagine
grateful for
what
that.
comes through very loud and clear in all of what you've said, but also what the other speakers today have said, is the word relationship. I think
Yes.
is probably, I always say if you were going to play buzzword bingo in the middle of the conference here, that would be one of the words at the
That's
top
right.
of the, or the
That's
word
right.
cloud, it would be like the big word.
Right.
And tying in the neuroscience of that, I think there's a title of a book, it's actually in the business world called Wired to Connect, but I honestly believe that we are wired to connect, and things go very badly for people, whether it's loneliness, whether it's trauma because untrusted, but then now all of a sudden breaking the trust relationship.
Yes.
Elizabeth actually asked a question, along the lines of what you said, Elizabeth. I was thinking as you were talking, whether it's a shortage of, psychiatrists and physicians, or it's a shortage of even in the schools where you don't have the reading specialists you need, but this idea of connection being therapeutic, the connection itself. I like to use, if people don't know the example, and don't fact check me on all the scientific evidence behind it, but one of the common phrases we use, it's the Weight Watchers effect. When people started looking at Weight Watchers, and the question was, is it the substance of what you're getting at Weight Watchers, or is it that you've got a group to belong to that's supportive and relational and everything else? I see a huge shift across a whole lot of sectors about relational, co-regulation, relational health, early relational health. I'm sure you know David Willis and others in the early childhood space.
Yes.
But to Elizabeth's point, so for teachers in a classroom or principals or superintendents or, quite honestly, people in business with colleagues, this idea of relationships, what could you extract, or do you see being able to extract some of these principles from something that seems really highly trained child-parent psychotherapy, and applying the principles to, let's all just figure out how to have better relationships, right? Engage people. Do you see a way of, because you've already done it, right, with primary care and with Head Start and child care, where you start to take the principles and move them over? But what about just, I want to be supportive to Elizabeth, or I'm a teacher in a classroom and I don't want to re-traumatize, but sounds like, if I'm careful. But at the same time, I want to just make my relationships with people that much more, supportive. Do you see that as an option?
It's a very, very important question that you are asking, and let me try to really address it with the depth that I think it calls for.
I'm going to do this so everyone can hear
Okay.
you. Yes, because
Which
everyone
is-
wants to hear your answer.
Okay. There are relationships, right? There are relationships in the realm of mutuality, of reciprocity, of respect, of there's a word that I actually have a great deal of trouble with. It's called mentalization, which is a fancy term for something that we do, which is very naturally, which is put ourselves in the position of the other. Trying to understand the perspective that another person brings that might be different from ours. And I tell you, I just spent 2 weeks with my 6-year-old and 2-year-old grandsons, and the 6-year-old has become pretty independent, and he said to his he said to his mother, when you get angry at me, I feel the same way that you feel when I don't listen to you. That's mentalization, right? Is putting himself in the position of his mother and seeing the connection. And his mother, bless her heart, said, what tends to happen first? And he said, good point. I think that is kind of like a mini example of office relationships, for example, right? It's kind of like, what is your place here? What do you want? What do I want? How can we find? One of the things in child-parent psychotherapy that I didn't speak about is understanding that parents have an agenda and children have an agenda. And often the agendas are very different because developmentally they're different. The child wants to stay up as late as possible, use as much screen time as possible, et cetera, et cetera. The parent has to socialize, has to go to work, blah, blah, blah. Doesn't mean that their agendas are incompatible. It just means that each one has their own very legitimate agenda that cannot coexist in exactly the same way, and they need to find a way that each of them gets a form of what they want and need that is manageable. Okay? So that's kind of in the workplace, I think, the model. When it comes to trauma, we are dealing with profound, intimate experiences that are at our core vulnerability. And in the office, there are power relationships where we cannot always trust that our vulnerability is not going to be used against us. And so translations need to be judicious, in other words. And I think that something that we can translate across the board is the idea of trying to understand the perspective of the other. And the question where I would be very cautious about is revealing very private things about ourselves in an environment where there can be ulterior motives about how to use that information.
So it sounds like, and especially for a group where people will be working with children who likely have had traumatic experiences, the answer would be you don't need to know what they are, and you actually kind of want to be careful not to probe because you're in a dynamic, if you're their teacher, for example, but that doesn't mean that you can't form a, know that they have something, that you can't form a supportive relationship that kind of honors it without digging too deeply and traumatizing them.
That's right.
Okay.
That's right. And I think that for there are times, however, that parents and teachers can really become allies on behalf of the child, and where a parent might say, his father left, or like that father that told Lilia about the mother dying of COVID, and there was a wonderful coming together about how to support the child. Yeah.
Well, great. Listen, thank you
you.
so much. I think
Thank
we're
you
out
so
of time,
much.
but it has been
Thank
such
you.
an honor and a
Thank
pleasure
you
to
very
have you
much.
here. Thank you.
Thank you very much.